So now we had cannot believe the time just flew. We just had an overview of an epidemiology prevalence of a MASLD and MASH, and then the risk factors.
My bank account?
Oh, sorry. Doctor, thank you. And some of the pathophysiology, and now the how do we test for these patients? So I'm going to ask all the speakers to come online, please, and then we'll have the Q&A sessions. I don't see any questions on the chat box, but so I'll just get started. So we just finished talking about the testings and screening. So do you think we should screen everybody in our clinic, or should we really test the ones for at risk factors only?
I definitely think there's not yet data to suggest screening among all. We're actually pulling a big study in Europe with 30,000 people who are reading that for screening the population. But I certainly think we have data suggesting that among patients with diabetes and obesity are clear risk factors, and also alcohol, we definitely should screen.
Okay, so is it Dr. Sebastiani?
Yes, I am I'm bringing, of course, the Canadian perspective, which is quite different than others. And I totally agree with the fact that the screening, also in our reality, is being done by risk factors, is risk factor based. And we are really trying to implement, and James is also part of this great process, this risk-based factor screening in endocrinological and primary care physician clinics for patients with type 2 diabetes. I think because the fibrosis is really the highest in this population in terms of speed of progression, of prevalence and incidence and so on, I think we should really starting with this population and then gradually expanding. And as Mazen presented, simple tests, especially, for example, in our reality of rural areas, remote areas, which is such a large geography of our country, is the way to go.
Yeah, but I definitely think that FIB4 is so easily and cheap to implement that should really be available in all practices and places. It's already with secondary tests like ELF test or something, so you can, let's say, enrich the referrals much better and avoid too much over-referral. So we actually have the tools, we have the knowledge, we know they work. So it's basically about getting them into play and then getting these patients out of the shadow because they are asymptomatic.
Yes, I totally agree. I think a lot of work needs to be done in terms of a dissemination and implementations of these NITs. So I guess next year we'll just have to think about, for at least from Canadian perspective, how we can actually do this effectively. So we'll probably learn a lot from our colleagues in Europe and in America, and looking to see how it's done. So Dr. Lazarus, I have just a question that I was asked before, that if all the primary care physicians manage MASLD, then will it actually translate into saving the healthcare cost? Because they're having some concerns that if all the primary care manage the MASLD, then the healthcare costs would not be reduced because the primary care are likely to order more unnecessary tests, and they could and then the primary cares may land up seeing more patients more frequently, rather than, let's say, hepatologists seeing them once every while. So I don't know if you are able to join online, but would love to hear your thoughts on that.
Yes, I'm here. Yeah. Can you hear me okay?
Yes, I can.
Well, I mean, it's a good question that needs careful analysis in each setting, comparing the costs. I'm not sure what unnecessary tests would be requested. I think if, as was suggested, a FIB4 was used and there was, and a patient was found to be in the intermediate zone and either a second test was ordered or you simply moved into treatment, which would be very similar to probably what you're treating this patient for anyway, because they would likely have diabetes type 2 or obesity or alcohol use. I'm not sure it would actually add that much more costs, whereas referring patients in a lower fibrosis stage to hepatology, I think will increased costs because of the increased costs for specialists, and there's just not enough specialists for the large number of people who have MASLD.
Well, thank you very much. We actually in Calgary, I'm working in the migraine space to see how the primary care physicians with that advanced knowledge and training in migraine can actually reduce the access, the wait time to the neurologist, improve the access, and see if we can actually reduce the cost. So hopefully that can give some answers. Dr. Noureddin, yes, your hands up.
I just want to agree with what Jeff said, but we actually did this cost-effective analysis study we published in Gastro in 2020. And that was following the ASLD guidelines in 2018. I took it to the heart when they said it's not cost effective. And we spent like 3 years doing this cost effective analysis. And basically, the primary care do not need to do further testing. It's a simple message. A FIB4, these tests are already there, followed by transient elastography as needed. Indeed, like the cost-effective analysis we did not start with FIB4. And I don't want to confuse the picture. We started with FibroScan, which arguably is more expensive just to start with it, right? And despite that, screening the type 2 diabetics in that study is cost-effective. So just imagine, and that's why the guidelines cited that paper, but they went to FIB4, which arguably is much cheaper than that. So if what's followed in the guidelines that is being done, it should not do much. It's a little bit extra work for the primary care, but on the other hand, I know we appreciate them. We don't want to give them extra work. On the other hand, themselves, they don't want to miss someone with cirrhosis. I just did the screening actually project, and they just brought it to my office, and I saw someone KPA of 64. That's not just like cirrhosis, that's a portal hypertension, and like the patient's in trouble. So we're seeing this patient, and the other 4 were normal. So despite that, I mean, the little bit steatosis, no stiffness. So it was very thoughtful process, and sure, it can evolve over time, but I think that's the best we got in a few years.
I think they anyway screen for all the other complications associated to type 2 diabetes. We just add another organ that's part of this game. So I think we shouldn't complicate it more and not push the liver. If I can allow there, James, I think there's important questions there around FIB4 and alcohol. And because now with the new way of thinking, this is a part of the spectrum. And I can confirm we've done a number of studies, biopsy-controlled studies, and FIB4 performed just as well in alcohol as it, or also bad, but it still performs just as well in that population. So actually can be applied over and should be the index test. And then, of course, you need a confirmatory test anyway. So that's actually make it kind of easy when we see that the testing pathway and the referral pathway are informed by more or less the same clinical decision aid tools.
Well, thank you very much. And I think also the whole change of the nomenclature was actually also helpful, especially when there's an alcohol use. As a matter of fact, I heard from one of the German speaker that there was no such thing as a non-alcoholic fatty liver disease in Germany. So actually, it was a very interesting comment. So how do we actually still manage those patients? But just we have 1 minute left, so I have a quick question about the limitations and the accuracy of the FIB4. Now, we do know that especially in some patients who are elderly, there is a bit of a question mark how accurate the FIB4 test is. So any thoughts?
I think, I don't know, there are many issues to say because tests in general, when they applied in low prevalence populations, and we have to say that we go to primary care, even though if we go to patients with diabetes, obesity with low prevalence, and then all tests perform worse. So what we see in our clinics is better performance. So we have to know that there is a significant risk of false positives. False positive is not necessarily a problem because then we send it to secondary test and say patient, it's no big deal. There will also be false negatives. And that's why if patients continue their risk factors, the FIB4 should be repeated in 1 or 2 or 3 years, depending on how the composition of the risk factors is.
Awesome. Well, I honestly would love to stay on and ask a lot more questions because I know it's not easy to have all of you at the same time. But I just want to thank all of you, all speakers for joining, and especially Dr. Krag. I do believe it's quite late over there, so thank you for joining at this time of the day. And it's really amazing presentations, and I've learned a lot personally, and I'm sure all our audiences have done so as well. So we'll be taking a quick break for next 10 minutes, so please come back to the session 6:43 in Eastern Standard Time, and we still have lots of fascinating sessions to go through. We just talked about all these pathophysiologies and the NITs and so on. Now we're going to talk about the nomenclature. Why was it changed? What about, and now we have patients with Mazen. What do we do with those patients from the management perspective? What about collaborating with the other healthcare providers and referral pathways? And we'll be hearing from some of the patients who actually had gone through the whole problem with MASLD. And we'll talk about the case studies and have some panel discussions. So thank you so much once again to all of you for joining and staying online. Once again, we'd like to thank our speakers and also the Federal Alliance for having us. So we'll see you in 10 minutes time. Thank you.